Let's get into how these signaling pathways might be implicated in different psychiatric conditions. We're going to go into a little bit of the signaling pathway, just a little bit, but then we're going to go into like the signs and symptoms of these different psychiatric conditions. And these are definitely fair game for your next exam. Now, I did a lot of work in psychiatry. That was my main focus when I was doing my third and fourth year medical school. And I saw every single condition we're talking about here today. I saw every single one of these, and they're fascinating. Schizophrenia, I think, is probably one of the most fascinating conditions out there. It's also one of the most devastating conditions out there. I literally would not wish it on my worst enemy. Schizophrenia is extremely tragic, but again, it's extremely fascinating because patients with schizophrenia have a completely altered perception of reality. Right? Patients I had with schizophrenia that they would have hallucinations. They would be like floridly psychotic. They were undergoing psychosis at the moment, and they would hear interesting things. Right? Oftentimes, the hallucinations they had would be like command type hallucinations, telling them to do weird things. I had patients that would see like just intense visuals. There was this one guy. He was like 45 years old. He came into the emergency department because he was having like really, really intense, vivid visual hallucinations. He was seeing demons. Like he saw devils on the wall, demons, all sorts of wild stuff. And he was in tears. Poor guy was like completely distraught. But fascinating, right? It's incredible what the condition can do. And we'll talk about some of the mechanisms behind that as well. A lot of it has to do with dopamine, like way too much dopamine being released. Depression is also really fascinating. Depression is, they're all sad. All these conditions are really, really hard to see. But depression is a very common psychiatric condition. It happens to a lot of people, including a lot of really famous artists, right? A lot of famous artists, a lot of famous musicians, performers, actors, a lot of creative types suffer from some form of mental illness. Often it's like depression, anxiety, it could be bipolar. It could be even schizophrenia, which we're going to talk about in a second. But one of my favorite artists, Van Gogh, he suffered from depression his entire life until ultimately he took his own life. But if you look at his art in person, if you ever get a chance to see an exhibit of Van Gogh, like go see it. It's incredible stuff. Like when I was in Washington, D.C., doing my clinical rotations in D.C., there was a private gallery that exhibited like tons of his work. And it was all of his repetitions. So he would do these repetitions where he would like paint an individual, and he would do it like multiple different times. So like one was the postman. It's the guy he's got a big beard, he's got a little cap on, he's got a yellow coat, and there's like different variations of that. And they're all just incredible. Like very beautiful work. And like his brush strokes, like everything just comes to life. It's almost like you're like tripping out when you see his work in person. It looks like it's like a psychedelic type experience. And that's kind of what he also perceived. He was on a certain med, and I can't remember what it is off the top of my head, but it also kind of affected his vision and his ability to see. Yeah, you do? Pull it up so I can remember. It's not atropine because it's something else. But it would affect his...
Foxglove plant.
Yeah. Digitalis. Yes. So he's on digitalis, and that affected his vision. And so that helped to contribute to some of his perception and his art. So really interesting stuff. You said it was foxglove? Yeah. Thanks for pulling that up, man. Yeah. So let's first talk about psychosis. Psychosis is mostly going to involve, again, dopamine. Right? Dopamine is going to be the foundation of psychosis. And if you have too much dopamine, that's not good. You want to have just enough to allow for motivation, right? Because that's the principal thing that dopamine does. It allows for motivation, learning, habit formation, things like that. But if you have too much dopamine, that can cause some serious issues in terms of like hallucinations, changes in perceptions, and things like that. There's a lot of mutations that might be involved in this. And the research on this is ongoing. Effectively, though, what happens is that when these genes are disturbed, right, then you're going to get increased resistance time that dopamine spends within the synapse. And it could be due to reuptake transporters. So it could be genes for reuptake transporters. It could be for the receptor sites. It could be for G protein activation. It could be for phosphatases. Lots of different genes could be involved in this. And the reason why I put this image up here, Hidden Valley Road, this book, I highly recommend it. If you have any sort of interest in psychiatry or like neurology even, this is an amazing book. And it's tragic. Huge family. How many kids was it? It's like 12 kids or something like that. Yeah, it's fantastic. It came out in 2020, I believe. Lots of kids in this family. Lots of them had schizophrenia. And it was the boys who had schizophrenia especially. And the story is so sad. The boys just were like really, really distressed. Like one murdered his girlfriend and then committed suicide. There was one that was also like very like sexually aggressive towards his younger sisters, like really tragic stuff. So it's a heartbreaking story, but also extremely fascinating because schizophrenia ran in this family, right? Not the parents, but the siblings. And so they were involved in a lot of our early research in schizophrenia. So there was a lot of research done, I think in the 1960s on this family. So really fascinating stuff. I highly recommend this book. It's wonderful stuff.
They know what the parents didn't have anything, but all the kids did.
Don't know. They were doing all sorts of genetic analysis on this, and I don't know what the outcomes of those studies. So it might be some of the discovery that we have over here. Like I actually don't know what the direct link is between that family and the research that was done on them. But I imagine that they, like the researchers at the time, discovered a lot of interesting things in like, you know, their maybe genetic makeup and whatnot. So super interesting. This is one of my favorite musicians, Syd Barrett, the first singer and guitar player of Pink Floyd. Amazing artist. And he was also dropping a lot of acid. He did lots of LSD. He smoked a lot of cannabis at the time. And eventually he developed schizophrenia. And I'll show a little slide about him in a second here. But great quote here: "No other disorder arouses as much anxiety in the general public, the media, and doctors than schizophrenia." Schizophrenia has inspired a lot of like art, a lot of music, so much. This great book. I haven't read the book, but I saw the movie, One Flew Over the Cuckoo's Nest. Ken Kesey is the one that wrote this. Ken Kesey, also a very interesting dude. So famous author. He writes One Flew Over the Cuckoo's Nest. It's about American mental health institutions, right? So if you haven't seen the movie or read the book yet, I recommend seeing the film. It's great. It's like one of Jack Nicholson's best performances. Ken Kesey also put together a group called the Band of, the Merry Pranksters. And they rode around the country in a big school bus, just dropping acid. And like, it was crazy stuff. And it was documented by Tom Wolfe, really great author, documented in Electric Kool-Aid Acid Test, which is another really, really great book. So here's Syd Barrett. So this is Syd Barrett before, right? Pretty, handsome looking guy, nice looking hair. He shaved his head, shaved his eyebrows. I just completely lost it. So here's some of the comments from Roger Waters saying that Syd always had odd thoughts, highly stressful childhood. His father died suddenly when he was a child. And then he got into a high-stress career, being a musician, right? Performing with Pink Floyd. Was using lots of drugs, like talking tons of acid. And then here's like the idea here is that highly creative people share an elevated risk of serious mental illness. And it's true. Lots and lots and lots of insanely creative people are, on the verge of mental illness of some sort, whether it's depression, bipolar, or schizophrenia. Speaking of art, this guy right here, this is hilarious. Louis Wayne. He was an artist in the 1860s, and he developed schizophrenia. And you can see the progression of his illustration of cats. So let me play a little video here. This video is so cool. I'm sorry that you saw this stuff yesterday. So it's a repeat from everything that you saw yesterday, because we talk about this in pathophysiology as well. But so the cats just get like progressively weirder over time, to the point where it's like not even cats anymore. Like this image right here, it's like I don't see a cat there, but so pretty wild stuff. It is crazy, literally. And then again with cats, there's actually been a link with cats and psychiatric conditions. So for those of you who have cats, watch out. So toxoplasmosis is a parasitic type of infection. One of the vectors for toxo is going to be rodents. And so when a rodent gets infected with toxo, it basically makes the rodent really attracted to the smell of cat urine. And so all of a sudden the rodent wants to hang out with cats. And the cats are like, oh, cool, got a new friend, all right? So gobble up the rodent, and now the cat has toxoplasmosis. So the cats are going to be like the ultimate like main carrier of toxo. But then you have intermediary vectors as well. Humans can also be infected by toxoplasmosis. And when humans get affected by toxo, it can be really dangerous for a pregnant mom. So if you work with patients that are pregnant, you want to make sure you tell them, hey, don't clean out your litter box. Try to avoid doing that. Have somebody else do that for you, right? Because if they ingest or if they, it gets into your respiratory system, and then that's how you get into your system. So if they ingest it accidentally, that can be teratogenic to the developing fetus. So really, really dangerous. It can also be linked to mental illness. Thinking about the crazy cat lady, right? That whole trope has some legitimacy behind it, because when women are affected by toxo, it can make them act a little bit more erratic, maybe a little bit more eccentric. For guys, it actually makes guys more aggressive, more agitated, right? So it can actually have some really interesting effects in people. And again, it can be associated with schizophrenia. It can be associated with suicidal ideation and attempts, cognitive impairment. So dogs are better. Sorry. Anyway, schizophrenia, again, dopamine imbalance, right? You have way too much dopamine. And other neurotransmitters could potentially be involved too. It could involve glutamate, could involve serotonin, could involve acetylcholine, right? So there's other neurotransmitters that could be implicated in schizophrenia. But long story short, with schizophrenia, you get these hallucinations. And that's what's one of the things that are characteristic of schizophrenic patients is either auditory or visual hallucinations. It's usually auditory hallucinations. Visual hallucinations in very severe cases. Those would fall under positive symptoms.
I feel like people with visuals should be like in a, what do I call it?
Well, they do. They get hospitalized. I mean, like the patients that I had, they would come into the ER. Sometimes like police would bring them in because they were like acting erratic in the streets. They would get brought to the hospital. And then we would have to stabilize them. Yeah, if they were like fluidly psychotic, we would have to stabilize them. And, a lot of the people that you see, like the homeless population, right? A lot of that is schizophrenia coupled with substance use disorder, right? They're schizophrenia plus drug use, like amphetamines especially. Amphetamines, what's one of the things that amphetamines do? What does it increase? Increases dopamine. That's one of the things that amphetamines do. And you're schizophrenic and you already have too much dopamine, then you take amphetamines, like, damn, that's too much. And a lot of our antipsychotic drugs reduce dopamine. And so, yeah. So unfortunately, like I said, the homelessness issue, it's a mental health issue. And these individuals are not getting the proper care that they need. When I was living in Dominica, there was this one guy, he's like this one homeless guy, and he was a frequent flyer in the hospital. He was taking injectable, and I forget what the drug is, but it's an injectable antipsychotic. It lasts for 1 month. You have to keep on getting it over and over again. So he was fine for like a month, and then eventually he would just be going crazy in the streets. And the town I was at was a small town, so I would see him in the streets, and then I would see him in the hospital, and he would have to get his injections again. Right? You have to get those periodic injections, and those drugs are good because it addresses non-compliance. But you have to be compliant at least once a month. You have to go to the hospital and get that injection again. Negative symptoms are going to be more like flat affect. So the person would just kind of like not have much in terms of like emotional expression. Avolition, which means being kind of like socially withdrawn. Age of onset is usually in the 20s. So that's your guys' age, right? Once you're my age, once you're 38, ain't got nothing to worry about. I got my own problems, but schizophrenia is not going to be one of them. So here's from the DSM, which is the Diagnostic and Statistical Manual of Mental Illness. And in the DSM, it basically, I really recommend, if you have any vague interest in behavioral health, get a copy of the DSM. You can get them for cheap now. I got mine on Amazon for like 40 something bucks. maybe 50. But it's a great book, and it goes through like background to all the illnesses and stuff, signs and symptoms of the illness. Like it's a really, really interesting read, and they go through some really, really weird diseases. Like there's some really like strange stuff that they'll talk about in there. So highly recommended. The sexual disorders in particular are very, some of them are kind of, I hate to say, some of them are kind of funny, but highly recommend reading it. But in the DSM, you have to have these symptoms for about 6 months to be technically diagnosed as schizophrenia. It has to be 6 months or longer. Now, the positive symptoms, again, those are going to be hallucinations, delusions, right? They have fixed false beliefs. That's what a delusion is. We had a lady that one of the first schizophrenic patients I saw when I was in med school. She had been on antipsychotics for decades, but she was still schizophrenic. She still had those fixed false beliefs, but it was just not as bad. But I was asking her, like, what's, you know, why did you come into the hospital? What's been going on with you? She's like, oh, I had this like thing implanted. She thought that she had like an implant, that the surgeons implanted some sort of like mind device, mind chip in her brain. And so like when she took the meds, even though it reduced her like symptoms, she still had those fixed false beliefs. So when a person has schizophrenia, even with medication, they still have schizophrenia because there's no cure for it. But there is the rule of thirds. This is part of the biopsychosocial model of disease, right? In terms of biology, that's your genetic predispositions. Psycho, which is psychological health, right? If you're able to withstand like stressors and changes in your life in a healthy manner, and also your social relationships. So that means your friends, your family, your job, your hobbies, right? If you have a balance of those three things, that can really help you like in terms of maintaining a good, healthy, balanced lifestyle. Whereas if any of those get kind of thrown off, if you at least have like one or two that are strong in that equation, that can be very helpful. So I'm not going to play this video, but Dr. Ellen Sachs, I highly recommend watching this video. This is her TED Talk, and she's a professor, and she has schizophrenia, but she's a professor, and she's highly functioning. She developed schizophrenia when she was your age, when she was an undergrad. And thankfully, she had good friends who helped her. They're like, what's going on with you? Like, she started talking weird, saying erratic things that made no sense. Her friends were like, whoa, what's going on with you? And so they stepped in to help. Her family stepped in to help, and she got the treatment she needed. And in her TED Talk, you'll hear that she is kind of like odd, right? She's kind of odd. You can tell there's something going on with her, but she's highly, highly functioning. And that's because she has a good psychological foundation, right? She has a way to deal with her stress, even though she has a biological predisposition to schizophrenia. And she has really strong supporting social network that helped her through. Now, the sad thing is with schizophrenia is that 1/3 of people will get better, which is good. 1/3 of people stay the same, but then 1/3 of people, regardless of intervention, will get worse. And that's the really sad part of schizophrenia, is those 1/3 that just do not respond at all to medication, to treatment, and things like that. So that's the rule of thirds, and that's the biopsychosocial model in a nutshell. Yes?
I know you were saying that paranoia can come from like fixed false beliefs, so that, or like believing someone can hear their thoughts. But I've also like seen people that have anxiety have paranoia.
Yeah. Oh yeah, totally.
So where is there another thing that causes that, where it's like there's no reason to be paranoid, but they are paranoid about something?
Paranoia can be brought about by different conditions as well, but it's like a symptom, right? Paranoia is kind of like a symptom.
Okay.
But yeah, you could get maybe paranoia with like anxiety as well. But when we talk about paranoia in terms of schizophrenia, we're talking about things like persecutory delusions, for example, right? Where you're thinking like you're getting persecuted by something. Like one of the schizophrenic patients that we had that I thought was so weird. He was getting into issues with his landlord because he started getting fights with his landlord or something because he thought that the FBI or the CIA were like investigating him for something for no reason, right? So he just thought these things that weren't actually happening. It wasn't true. And he had these persecutory delusions. He thought he was being persecuted. And that happens to a lot of people with schizophrenia. But not just schizophrenia. You can get that with other diseases too, right? So it's kind of just like a symptom, right? It's not something that classifies the disease. But it's one of the constellation of symptoms that you find within schizophrenia. Here are other conditions. So you got schizotypal personality. This is like a person who's very odd. They might look a little weird. They dress a little weird. They have maybe very strange, eccentric thoughts, right? These people actually sound really cool. This is like a cool person to hang out with. You want like those weirdo friends. And then there's schizoaffective, which is schizophrenia plus a mood disorder. There's two subtypes. There's bipolar subtype and there's depressive subtype. The bipolar subtypes are like really wildly entertaining people. My favorite patients when I was working in the hospital were schizoaffective with a bipolar subtype. They were often very funny. They would say like the most wild, amusing things that you could possibly imagine. So never a dull moment. Schizoid personality, this is going to be a person that like lives out in the middle of nowhere. They don't want to talk to anybody. They don't want to engage with society. Oh, maybe. Yeah, maybe, probably. I wouldn't be surprised. Schizophreniform, which is like schizophrenia, but it's not as long as 6 months. Brief psychotic disorder. This can happen to you overnight, where you just all of a sudden go psychotic. It doesn't have to, it might not be drug induced. It might not be anything else. All of a sudden you just go psychotic and then you get better again. Crazy. That happens. My colleague, Dr. Jackson, had a patient just like that. She was actually a nurse. She was floridly psychotic. They thought that she was on drugs. They did a urine analysis. They did a drug panel on her. Totally clean. She like punched the nurse. The nurse punched her back in the hospital and they were like restraining her. The next day she came to, she was completely fine and she was horrified. She was like, I can't believe all that happened. She had no recollection of what happened. People told her what happened and she had no recollection. So that was a brief psychotic disorder. Short-lived, within 24 hours. You can just go crazy like that and then snap out of it the next day. So.
Do they know anything about that? That's insane.
I feel like it's a genetic thing.
It must be a genetic thing. I don't know. Yeah, it's not really well understood. So let's talk about mood disorders. Mood disorders, it could be involving your neurotransmitters. It could be due to low amounts of neurotransmitters. So there's different drugs that affect that, right? So there's drugs that, for example, can affect dopamine, norepinephrine, epinephrine. So those could be potential targets. Serotonin might also be a target, but that's not the full story, right? It's not just serotonin, which I'm going to show you in a second here. The genes that might be involved, it could be your calcium calmodulin protein kinase. It could be synapses that are associated with those different neurotransmitters and proteins. So certain drugs that could be used to treat this, you can use monoamine oxidase inhibitors, right? What do monoamine oxidase inhibitors do? They prevent the degradation of monoamines, including serotonin, dopamine, things like that. And then classically, you're seeing a lot of prescriptions of these, right? Reuptake inhibitors. So like serotonin reuptake inhibitors. So SSRIs, selective serotonin reuptake inhibitor. SNRI, serotonin norepinephrine reuptake inhibitors. And so that one in particular would give you more energy, right? A lot of people with depression, they get really kind of down in the dumps. They get very tired and fatigued, which we'll talk about in a second. So let's talk about depression in terms of its symptoms. So again, like lots of artists have these types of conditions. Jimi Hendrix was a very, very depressed individual and probably contributed to his incredible talent, his incredible music, his creative potentials. Also probably contributed to his substance use, right? Which ultimately led to his demise. What was it? He died in like 1970 or something like that.
27 Club.
He wasn't.
He wasn't?
No, I don't think he was. I think he was older than that. I think he was. Janis Joplin was 27. I don't think he was. Was he? He was. He was 27. You're right. He is part of the 27 Club. My bad. Janis Joplin, Jim Morrison, right? Yeah, so I forgot about that. But anyways, he died in, I think, 1970 or something. Yeah, 1970s was when he died. I am going to test you on the lyrics to Manic Depression, so make sure you memorize all of these for the next exam. So these are the major symptoms of depression: sadness, apathy, weight changes. They could be weight gain or weight loss because you get changes in appetite. Decreased energy. This is the scary one, suicidal thoughts. Right? A lot of these patients with MDD, especially major depressive disorder, do sometimes kill themselves. Mood swings, insomnia, crying for no reason, right? One of the my favorite series of Pablo Picasso was his like blue series where he did a bunch of paintings with like a blue theme to it. So this is one of his really, really gorgeous paintings. Poor guy on his guitar. So here are the major types of depression. Major depressive disorder. That's like the heavy hitter. That's the really bad one. It happens for at least 2 weeks, right? So you have to have really nasty episodes of depression that interfere with your life. These diseases, you know, we all get kind of down in the dumps, but does it interfere with our daily life? Not always, right? But if it starts to, like if it starts interfering with your work, your school, your friends and family, your social life, that's when it becomes clinically relevant, right? That's when it becomes an actual clinical diagnosis. Postpartum depression, this one's also pretty scary. This happens to a lot of women. Like when you're pregnant, there's going to be lots of hormones involved in that. And those hormones can be mood elevators. So pregnant women will sometimes have like a really elevated mood during their pregnancy. As soon as they deliver the child, those hormones tank, they go back down to baseline, no longer the elevated mood, and that can cause postpartum depression. It's scary when it makes its way into postpartum psychosis, because at that point, these moms can be kind of dangerous. They can be dangerous to themselves, but they can also be a danger to their baby. Yes?
I've also heard this could just not be correct at all, but I was hearing about postpartum depression, and people were saying like women feel like they don't have a purpose anymore because they like gave birth already, and then they're like, oh, like that was the thing that was giving me purpose.
Oh, that's so interesting. I've heard about that with people who are a caretaker for someone, and then the person maybe passes away, and all of a sudden the caretaker's like, wow, I'd like dedicated my past several years to like taking care of this person. Now they're gone. I've heard about that. I haven't heard about this with delivering the baby, but I wouldn't be surprised. But I mean, they do have a kid there that they still need to take care of. They need to breastfeed and all that stuff. So I don't know. The mind is a very complicated thing.
Like, gets rid of their identity.
Maybe gets rid of their identity as a pregnant person, right? Because pregnant women, they get a lot of like, you know, if you like take public transit, like especially in like New York, they have these signs like, you know, give up your seat for a pregnant woman. And sometimes people don't do that. And it's just like, dude, get up, dude. Especially if it's like a young guy. It's like, come on, be a gentleman. There's a pregnant woman right here. Let her sit down. Anyways, seasonal affective disorder. This especially happens if you live in like northern latitudes. Like when I lived in Portland, Oregon, oh my God, I got seasonal affective disorder so bad. I was really depressed during those winter months. It gets dark at like 3:30 in Portland. 4 o'clock. And then I would go to work in the morning. It's dark out. I would get off work. It's dark out. And it's like, where's the sun, man? I grew up here in Arizona. I want to see some sun. Then the summer hits, and the summer is awesome. It gets dark at like 10:30 at night, and everybody's partying in the streets and stuff. It's super cool. A student in the patho class yesterday asked me about summertime blues. They're like, can't you get that kind of here as well? And it's different. Right, you can get the summertime blues because the summers here suck and there's barely anything to do outdoors, right? Because it's too brutal. But it's not the same mechanism. Seasonal affective specifically deals with melatonin, your circadian rhythm, right? When it's dark, all of a sudden your brain's like, oh, it's bedtime. It's like, no, dude, it's 3:30. It's not bedtime. So, yeah. There's ways to go around that too. Like I've heard of people using like red lights or certain lights that like, maybe not red lights. It's like lights that help to... It's either that or blue lights to help to kind of like trick your brain into thinking it's still daytime. It might be red light. I can't remember what it was exactly, but people use it commonly up in like Seattle, Washington, Oregon. Dysthymia means you're down in the dumps for at least 2 years. And it's kind of like a subclinical depression. It's like the person just kind of, maybe they're a little moody, right? They're like slightly depressed. It's not depressed enough for them to like get a diagnosis of major depressive disorder, but they feel like not that great for like at least 2 years. Yeah.
Sorry, man, it's not a random question.
You're good.
First of all, is that a Picasso also?
This one?
Sun picture from the one before?
It is not, and I don't know who did that. I probably should have found out who did that and credited it.
And secondly, do you think, you know, like the feeling in the afternoon when it's like 3 o'clock and there's like a certain way that people feel?
Yeah, it's probably after you eat.
No, like even if you haven't eaten, like I don't know how to describe it, but that is similar to like that summer blues.
Where it like towards like the early afternoon, you're just kind of like...
The sun is like not going down yet, but it's like kind of there. And it's a very weird feeling that I do not know how to describe.
Yeah. Yeah, I know some countries, they have that siesta, right? After lunch, they all like maybe take an hour off the day to like maybe take a nap or do whatever, right? Americans like to work too hard. But if you live in a place like Italy, they don't like to work very hard. That's like, they just shut down their stores and stuff. They're like, we're taking a break for like an hour or two.
In India, everyone's taking a nap after lunch.
Oh, yeah? Nice. Yeah, I commonly go into like, what do you call it, food coma. So what are the causes? Again, neurotransmitters could be the underlying cause, but it could be other things too, right? Situational things could induce depression. You got fired from your job. You got dumped by your boyfriend or girlfriend, right? Or you had a family member die. What's up, man? You had a family member die. Like those things will make you depressed, right? Or you're sick. You have like an underlying thing going on. Maybe you have cancer. Maybe you had a heart attack and now you're depressed. There's lots of things that can cause depression, which is perfectly normal and understandable, right? But the serotonergic model is what the pharmaceutical industry has really lashed itself onto. And that's why today, 1 in 8 people are on some sort of antidepressant drug. Meanwhile, have the rates of depression gone down at all? No, right? They have not gone down, as we talked about the other day when we were discussing alternative therapies, right? The rates of depression have continually gone up. And so this is part of that article that came out now 2 years ago. It was a great article. It took the world by storm at the time. Like the media was all over this because it's wild. Like it says the main idea of serotonin research provides no consistent evidence of there being an association between serotonin and depression, and no support for the hypothesis that depression is caused by lowered serotonin activity or concentrations. So that was a meta-analysis, or actually it was a systematic review that was conducted by these researchers. And it's a really fascinating case. Right? So serotonin is not the full picture. It's multifactorial. There's other things going on. Now, to diagnose patients with depression in the clinic, this is one of the inventories you could use, right? So little interest or pleasure of doing things, that's one criteria. Feeling down or depressed or hopeless. Sleep problems, either not being able to sleep or you're sleeping too much. It's not uncommon for a person with major depression to be in bed like literally all day, right? They don't want to do anything. They have no energy to get out of bed. Feeling tired with no energy, poor appetite, or overeating, right? Because some people cope. That's part of their coping mechanism, is by sometimes eating. Feeling bad about yourself, feeling like a failure, feeling guilty that you feel like a failure, right? All that stuff. Trouble concentrating, moving or speaking slowly. They call this in psychiatry psychomotor retardation, which is the technical term for that. So that means you're slower in your thought. You're actually moving slower than you normally would. Thoughts that you would be better off dead. That's the scariest one of all these, right? Because that's where you start getting into the suicidal territory, right? Suicidal ideation, having a plan in place, right? You want to ask a patient, if you work in psychiatry, like, do you have a plan in place? Because some people might be like, oh man, I just wish I was dead, but they don't have a plan, right? But if they have a plan in place, like, oh yeah, I got a gun, or oh, I'm going to hang myself, right? That's really scary. That means that they've already been really thinking about it. SIGI caps is the mnemonic that we use. SIG, so sleep disturbances, loss of interest in pleasure. We call this anhedonia. So think about hedonism. That's a person who like pursues pleasure all the time. It could be drugs, sex, gambling, whatever. If you're anhedonic, that means you are not able to experience pleasure whatsoever. Things that maybe previously gave you pleasure, hobbies, hanging out with friends, things like that, no longer give you pleasure. Feeling guilty, low energy, concentration, appetite, psychomotor function, and then suicidal ideation again. So I think this is a good spot for us to continue for next time. We're going to talk about another type of mood disorder. So that's going to be bipolar. Right? Bipolar disorders involve mood changes too. That's why it's called bipolar depression. So we'll talk about this next time. Any questions? Serotonin is like you're safe, you're comfortable, you're happy. Dopamine is more like you're motivated, reward pathway, right? Like you completed a task and you did well on it, and all of a sudden your brain says, that was good, do that more, right? That's what dopamine does. So it's the reward pathway.
You have like increased dopamine synaptic cleft, right?
Mm-mm.
No, you have less.
No, you're going to have less of everything basically with depression.
Wait, so what do antidepressants do?
Antidepressants like SSRIs are going to help to increase things like serotonin, increase things like norepinephrine. There are ones that can help to increase like dopamine, for example. I'm trying to remember, bupropion I think is one that involves dopamine as well. I might be wrong about that.
I feel like they can have such an opposite effect.
The antidepressant drugs, everyone's biochemistry is different. The pharmaceutical industry loves SSRIs, but not everybody responds to them. As a matter of fact, most people don't. There's a handful of people that do, right? But not everyone does.
Because schizophrenia is too much dopamine, right? Or just like an imbalance.
Too much dopamine, way too much dopamine. Yeah. So with schizophrenia, you reduce the amount of dopamine. That's part of what those antipsychotic drugs do.
And that's also why they like commonly become substance users.
It could be part of it, man. I don't know. It's like schizophrenia is such a weird thing. Like, I had a friend of mine from high school who became schizophrenic, and he just got worse and worse and worse. And he was like smoking meth all the time and stuff. Like, yeah, it's brutal stuff. It's like a lot of people with mental health like self-medicate too. It's very common for them to self-medicate, but then they don't take the drugs that probably they should. Instead, like they don't take the prescribed meds. Instead, they self-medicate with drugs and alcohol and stuff like that. So it's a very common thing, man. That's why a lot of psychiatric conditions are so difficult to treat, but at the same time, they're so fascinating. So fascinating. All right, guys, it was a pleasure. Have a wonderful weekend. I'll see you all next week. And next week, we're going to be talking about neuroplasticity. So it'll be fun. Yep, my pleasure. Take care. All right, y'all. So last time we met, we were finishing up on depression. So we talked about all the different signs and symptoms that are significant in depression. Siggy caps would be a good mnemonic to be able to figure out what the signs and symptoms are. You know, sleep issues, loss of interest. We call that anhedonia. Compare that to hedonism, right? Hedonism is where a person is just like pursuing pleasure, whether it's drugs, sex, alcohol, things like that. Whereas anhedonia, you can't experience any pleasure. Energy changes, concentration changes. And then the scariest one over here is a suicidal ideation, right? That's when patients, if they're depressed enough, they will sometimes commit suicide, or at least attempt to do so. Who are the ones that are most susceptible to suicide? If you work in a clinical setting and you're working with these types of patients, you always want to ask them, have they had any prior attempts? When a person has a prior attempt, that's like really high risk for trying it again at some point in their life. In terms of gender differences between males and females, women actually attempt suicide more often than men do. But men are the ones that are usually more successful at suicide. They use more lethal means. Women, when they try to commit suicide, it's usually like overdosing on certain medications, sometimes even like self-cutting. Whereas guys will usually do something more drastic. Gunshots, hanging, things like that. So no joke, it's really, really brutal stuff when it comes to major depressive disorder. It's a very scary situation. Now, this is where we stopped last time. We stopped on bipolar disorder. And this also falls under mood disorders because bipolar has has a depressive component to it as well. Bipolar 1 and bipolar 2 both have a depressive component. These are the genes that are involved that have been researched in bipolar. There's a bunch of them, and I'm not going to make you guys responsible for all of these, but there might be a gene involving the monoamine oxidase enzyme. Right? So in other words, that might affect breakdown of things like dopamine, serotonin. There could be other second messenger systems that might be involved as well, like G protein receptor kinase. Could also involve serotonin receptor, the serotonin transporter. So lots of different genes could be involved in the manifestation of bipolar. And the two subtypes of bipolar are bipolar 1 and bipolar 2. Bipolar 1 is the more scary of the two. Bipolar 1 patients have more significant mental health illness. So the manic phase in bipolar 1 is characterized by 7 days of mania, at least 7 days, during which time the patient literally destroys their life. Manic patients could go on gambling sprees, spend all their money. They could go on sex binges and basically sleep with anything that moves and just ruin their relationships. They could go on drug binges and do every single drug under the sun and then just totally ruin their lives. Manic patients are also going to have, first of all, they have delusions of grandeur. They feel like invincible, unstoppable. They feel like they're on top of the world. They'll have decreased need for sleep. So they'll be extremely sleep deprived because they have so much energy. They can also become pretty violent too. So bipolar 1 patients are in particular a little bit more aggressive. People often misunderstand schizophrenia and they think that schizophrenic patients are like the ones that are the most dangerous. In reality, a schizophrenic patient is more likely to be the victim of violent crime or a violent attack. Whereas bipolar patients, when they're manic, they are often perpetrators of violent crime. They tend to have a higher degree of homicidality, right? They're more homicidal. Whereas during the depressive phase, after the crash of mania, their depressive phase makes them more likely to commit suicide. So suicidality is much more concerning during a bipolar patient's depressive phase. Yeah.
This is just a random question about bipolar. Like, what if someone commits like a crime? Like, is that taken into consideration? Because technically they may have not been aware of what
that. Yeah, I mean, they do all sorts of. They have like people come in doing not consultations, but they're like expert witnesses, expert testimony. Right? They'll have psychiatrists, psychologists come in and provide expert testimony, and if the patient is indeed deemed what's it considered, and not incompetent, there's a term for it. I forget what the term is in a legal setting, but a patient might be deemed like, psychiatrically not unfit for trial, but they it might have been like the underlying cause of their crime. I forget what the term of that. Criminally insane, I guess, would be kind of not a super technical term for it. It's case by case, right? Every case is going to be litigated differently, and it depends on the jury, right? The jury is going to ultimately, determine whether or not the individual is guilty, right? And they're going to listen to the expert testimony, and they might think the expert testimony is garbage. That happens, right? Or they might actually pay, credence to the expert testimony. So, yeah, I mean, every case is going to be different. But yeah, that's absolutely something that would be put into consideration, right? If a person has schizophrenia and they commit a homicide or something like that, they're going to take into account the fact that this person is schizophrenic. Does that mean that they get out of jail free? No. They're going to be, instead of like put into a regular like maximum security prison, they might be put into like a psychiatric type prison, right? There are psychiatric prisons. There was a guy, for example, this was one of my patients. He wasn't even really like mentally ill, but he murdered his father. And, I was reading through his case record, and he came into our hospital because after he was released from an institution, he was there for 20 years. It wasn't a prison, but it was a clinical institution. And he was in there for 20 years, during which time he was trying to get a degree and get a certificate for becoming a dental hygienist. When he got released, nobody wanted to hire him because of his criminal history. And so he became really depressed and he attempted suicide. And so that's when he was admitted to our hospital. And then I was talking to the guy, and you would never imagine that this dude ever murdered his father. Nicest guy. Super meek, super quiet, very but very friendly, very gentle. But why did he murder his father? It's because the father was so violent and abusive that if I were in his shoes, I probably would have done the same thing. He was just pushed to that level of desperation. His sister left the household, and she actually became a very successful investment banker. She was working in Wall Street. She came to the hospital to visit her brother, and she was totally fine. But she left the abusive situation because she couldn't tolerate it. But the poor guy, he stayed in the household and then eventually took an axe and beheaded his father in his sleep. So I was reading through the records. I was like, wow, that is gnarly stuff. And so I was a fourth-year med student at the time, and I was doing a sub-internship. So I was kind of in terms of med students, I was kind of on the top of the pyramid for the med students. So there was other third-year med students that were doing the clinical rotation, and I was like, hey, first let's go interview the patient together, and you guys can tell me what you think afterwards. And then I want you guys to read his case report. And so we went in there, we talked to him. Nicest guy. You would never know. And then I was like, all right, now go read his case report and let me know what you think. They came back, they're like, oh my God, like he did that? I'm like, yeah, he did that. Wild stuff, totally wild stuff. But, he wasn't put into a prison per se because he was basically pushed to the brink of insanity. And so I think that he probably had some like expert testimony during his trial. I don't know the case of his actual trial, but that's probably what happened. But yeah, they'll litigate it on a case-by-case basis if someone commits something atrocious. So yeah, it's a wild field. There's a whole entire subset called forensic psychiatry. And I only went and saw one patient, and he was a patient, but he was also an inmate. He was a prisoner. And when you go into the forensic psych ward, it's like, have you guys seen Silence of the Lambs or any of the Hannibal Lecter movies? Like when Clarice goes to like the maximum security psychiatric prison, they go through like multiple like doors, you get screened, you get checked, there's prison guards in there. It's hardcore stuff. And then the inmate and the patient, there's like behind a plexiglass wall. It's really wild. I only went in there once to see what, it's really interesting stuff. But you have to be a special kind of person to work in that field. Extremely dangerous because you're dealing with like I'm talking like the most violent people you could possibly imagine. So interesting stuff. Anyways, so bipolar 1, that's 1 week of manic symptoms. Another story. Like I said, some people go on sex binges and they ruin their lives. He's not really a friend of mine, but he's like my best friend's friend. And his wife is bipolar. And when she had her manic episode, they have 2 kids together. She like left the family, and she was like sleeping with everything that moves. And then she started shacking up with this guy. And my buddy's my buddy's like friend was like calling him on the phone constantly, like, dude, what am I gonna do with the situation? This is horrible. And eventually she came back to normal. And he let her back into his family and her household. It's wild. Yeah, he's got much more. He is a stronger man than I when it comes to something like that. Like, I wouldn't necessarily tolerate that. But some people do. And, I guess it's part of the condition, right? When you have people like this in your family, you might have siblings, you might have a parent, you might have somebody in your family that has these types of conditions. And it's good to exercise a bunch of patience because you kind of have to. Yeah, because it's tough. Sometimes they'll go into their manic episodes. And you want to be there for them, especially with their medication, because when they're manic, do they want to take their meds? No. Why don't they want to take their meds like lithium, lamotrigine, and mood stabilizers? Yeah.
They're the best, right?
Yeah.
I think they need medication.
Being manic is awesome. It's like being on top of the world. It's like being on all sorts of stimulants, right? You're just like feeling jazzed, but it's ultimately destructive. Right? They destroy their lives. So it's good to take their meds. Lithium has side effects. There are side effects of lithium, but it's better than going manic because manic episodes are brutal. These patients wind up in hospitals when they're manic because they're so self-destructive. There was one guy we had drove from California all the way to New York City for no reason. Like when we were talking to him, we're like, why did you do that? He's like, I have no idea. His wife like flew out to come get him. He just literally got in his car and just randomly drove across country for no reason whatsoever. And then he wound up in the hospital. Wild stuff. Yeah, people with bipolar will do some pretty interesting things. Bipolar 2 is not as bad. Bipolar 2 is the less intense version of bipolar 1. It's 4 days of a manic episode. They call that hypomania. And why do I have all these pictures of like famous people? Like lots of famous people, lots of successful people have had bipolar. Winston Churchill, he was very, very, very bipolar. He would also go into these very deep depressive episodes. Winston Churchill, Prime Minister of Great Britain during World War II, especially to help defeat the Nazis, right? Pretty important dude. Wild guy. Controversial, but pretty wild dude. Robin Williams had bipolar. That's not why he killed himself, though. I thought that it was bipolar that drove him to commit suicide, but it was Lewy body dementia. Like towards the end of his life, he developed Lewy body dementia, which is like a combination of Parkinson's disease and Alzheimer's. And he was misdiagnosed, which people with Lewy body often are misdiagnosed. And so he was misdiagnosed, and he just like couldn't handle it. He was having hallucinations and all sorts of stuff was happening. And he ultimately decided to take his own life. Russell Brand, wild dude. Yeah, he's awesome. He's a wild guy, and he's totally crazy. And he's had manic episodes, and like he was married to, I think, Katy Perry, ruined their relationship because he was also super promiscuous, doing tons of drugs, and he just was losing it. And so I think he got fired from MTV, right, because he was so absolutely unhinged. Like, and he's also extremely brilliant and also very like charismatic and funny. Like, people with bipolar sometimes are very high performers. But then the depressive episode hits, and that's when it's like really scary. Now here's from the DSM. So check out some of these symptoms, right? You got inflated self-esteem or grandiosity, decreased need for sleep, chatty Cathy. They're just more talkative than normal. They call this pressured speech. It's like they're trying to push out as many words as possible, right? Flight of ideas, distractibility, right? Increased goal-directed activities. So it could be like, oh, I'm starting this new business. I got this brilliant idea, and it's going to like revolutionize society, and I'm going to spend all my money into the startup, and all of a sudden it's like, yeah, that startup was really a crappy idea, and you just basically wasted all of your life savings on this idea that just wasn't going to work. Excessive involvement in high potential for painful consequence type activities. I'm talking spending sprees, sexual, like indiscretion, just all sorts of self-damaging activities, right? Very similar to Russell Brand, right? He's like a poster child for bipolar. Again, with bipolar 1, at least one manic episode that lasts for 7 days. Bipolar 2, hypomanic episode. So that's 4 days of mania. Again, during the depressive episode, extremely high risk of suicide. Treatment involves mood stabilizers. So lithium is a really, good treatment for these patients. Lamotrigine is another one. Lamotrigine is a anti-epileptic drug, and so it basically kind of slows down the neuronal firing, so it can help to stabilize these patients. There's certain antipsychotics that could be used as well to help these patients. So lots of different treatment options. Fortunately, though, bipolar 2 is the more common, right? Bipolar 1, much more severe, but less common than bipolar 2. Now, switching gears into anxiety disorders. Anxiety disorders, the main thing that's going on with anxiety disorders is heightened stimulation of the sympathetic nervous system. So catecholamine release. When you have a panic attack, patients with a panic attack will get chest pain, shortness of breath, they'll get diaphoresis, which is sweating, right? What do those symptoms sound like to you? Heart attack, yeah. So patients with anxiety will sometimes go to the hospital because they literally think they're having a heart attack. They'll get chest pains, shortness of breath, all that stuff. But what is it? It's just anxiety. They'll hook them up to an EKG machine. They'll run their EKG, and maybe they'll see, they're tachycardic. They have an accelerated heart rate. But in reality, their heart is actually just fine. It's just they get this flood of catecholamines that basically result in a sympathetic nervous system reaction. So how do you treat it? You can use drugs like benzos, right? What's the mechanism of action of benzos? Which neurotransmitters or neuroreceptor? Oh, it's right there. GABA receptors. So if you stimulate GABA receptors, that is going to reduce neuronal firing, right? So it basically lets things calm down a little bit. So benzodiazepines are an option. You can also give other types of drugs, like it might involve serotonin, so you could give serotonin reuptake inhibitors. You could give monoamine oxidase inhibitors if serotonin is like the major thing that's underlying the cause. Some of the genes that might be involved in this could be the catechol-methyltransferase gene. So that's what allows to break down certain neurotransmitters like catecholamines, right? And so if you have a disorder in that enzyme, You might have too many catecholamines being released, too much norepinephrine, too much epinephrine. Again, treated with GABA receptor agonists like benzodiazepines. Other genes could be involving glutamic acid decarboxylase, which is what allows for glutamate to be transformed into GABA. So you could have perhaps reduction in GABA naturally, and you might have too much glutamate. And remember, glutamate, excitatory neurotransmitter. So you have way too much excitation. So there's lots of things that could be involved in anxiety disorders. So what's going on with anxiety? Anxiety is a normal thing, right? We all get anxiety. We get anxiety when we're about to have to perform on something. Maybe you're getting anxiety because you're going to a job interview, or maybe you're getting anxiety when you're like going on a first date, right? There's lots of things that can cause anxiety, and that's perfectly normal. There's two types of stress. There's eustress, so that's EU stress. That's good. That's the normal type of stress. That's the type of stress that gives you the motivation to study, work hard, complete tasks, be productive. But there's also distress, and distress is inhibitory, and it's non-productive, right? You get so stressed out and so overwhelmed that you're not able to actually function properly. Like if you're taking an exam and all of a sudden your stress gets too much and it starts fogging your mind and you can't concentrate properly, that's distress, right? It's crippling you. It's making you not able to function properly. What's the underlying causes of actual anxiety? That's going to be that fight and flight response, adrenaline, catecholamines. And usually the anxiety subsides, right? So the anxiety subsides, but for people who have a diagnosable condition like generalized anxiety disorder, it starts interfering with their day-to-day activities. It interferes with their work, interferes with their relationships, it interferes with their education, interferes with all sorts of things. Lots of people get this. 40 million people in the United States. That's a lot of people out of 300 some million, right? We get there's lots of anxiety. This is the most common of the DSM conditions. Conditions that are diagnosed in the DSM, anxiety is on top of the list. Famous artists, like I mentioned last time, lots of famous artists, lots of musicians, performers have these types of conditions, right? Scream, Edvard Munch, painter, he painted the Scream. He was having a panic attack. And he turned it into art, right? A lot of artists, that's how they process their emotions. They create beautiful works of art that we all love and appreciate. Again, anxiety is normal so long as it's not inhibiting your ability to function properly. Like I said, anxiety disorders are the most common of mental disorders. 30% of people will get something like this at some point in their life. That's a lot of people. 1 in 3 people will have an anxiety disorder at some point. Again, this could be due to a lot of things. I mean, this could be due to stress. Maybe you had a loss in the family, or maybe you had a situation where you got fired from your job, right? It's normal to experience anxiety under those conditions. But usually if you have, I don't want to say if you're normal, right? But if you're able to cope with stress, usually that grief, that period of challenge will, you'll overcome it. But some people don't overcome it very well. So they have to have professional intervention. Then when a person has anxiety, like a panic attack, they start avoiding things that might trigger their anxiety in the future. So it becomes kind of like this perpetual cycle, right? They want to try to avoid stressful situations to the point where it starts interfering with their life. How do you treat it? You treat it with psychotherapy. You can also treat it with pharmacotherapy. So pharmacotherapy, again, anxiolytic drugs like benzodiazepines. Psychotherapy, like cognitive behavioral therapy, CBT. That's a really, really good approach that is highly successful to treat all sorts of psychiatric conditions, especially mood disorders. It can be very helpful with mood disorders. Why do people get this? It could be family history. It could be genetics. It could be environmental factors, psychological development. So many factors come into play. It's multifactorial. So you can give them, again, CBT, psychopharmacology, like benzodiazepines. Antidepressants might also be helpful. Beta blockers. What do beta blockers do? Yeah, basically parasympathetic. So they block the sympathetic activation of the heart. And so beta blockers are going to block the beta-1 receptor in the heart. And so then you get more of a parasympathetic response. That can help reduce anxiety, especially like performance anxiety. One of the residents, when I was doing my first psychiatric rotation, one of the residents had some very severe performance anxiety, and his colleagues knew that he had this presentation that he had to do. This is like a presentation to help him like move forward in his residency program. His colleagues all conspired to spike his drink with a beta blocker. And so they gave him, I think it was like metropolol or something. And during his performance, his presentation, he did really well. And then afterwards they were like, hey, you know, we snuck you a beta blocker in your drink.
Was you mad?
I mean, I'd be mad. I don't know if he was mad, but I wouldn't suggest roofing your colleagues, even if it's for a good reason, right? A good end, right? So they can like perform better. But but metropolol and drugs like that have very, very minimal side effects. They're actually very, very safe drugs. And so for people who have anxiety, panic attacks and things like that, it can help to regulate the heartbeat. So panic attack. All these conditions share panic attacks as a symptom. So it is a symptom. Panic attack is not a disorder. This is where you're like feeling like you're dying. Like literally, you feel like you're having a heart attack when you're having a panic attack. You might also have a fear of like that you're losing your mind, that you're going mad. This feeling of impending doom, like something really terrible is about to happen. Right? These are the types of things you might see with a panic attack. Chest pain, palpitation, shortness of breath, hyperventilation, right? These are heart attack symptoms, but it's only anxiety. So it's a severe sympathetic reaction. And again, you get these panic attacks with all these conditions. So GAD, which is the more severe type of anxiety, generalized anxiety disorder, PTSD, panic disorder, agoraphobia, any of these can cause panic attacks. So let's talk about some of these. So we got panic disorder. This is where you're getting several panic attacks that are reoccurring. They can happen unexpectedly. They could happen expectedly in response to a fear, right? If you have like a specific phobia of some sort, but they could just happen randomly. Some people just get them out of the blue. You get you get at least 1 month, if not more, of concern about getting another panic attack. Like you start ruminating on panic attacks. You're like, I'm going to get another one. And then it sort of becomes a self-fulfilling prophecy. You get like more and more fear of getting more panic attacks. And then it happens more and more. Right? So it becomes kind of like a cyclic type of reaction. And again, all your heart attack type symptoms, fight and flight response, palpitations, diaphoresis, tremors, chest pain, all that stuff, shortness of breath, syncope. You could even pass out if the panic attack's bad enough. And then notice with the gender disparity here, these types of disorders are more commonly seen in women, sometimes twice as often as you see with men. Why is that the case? Women in general have like a higher threat response, which makes sense because, generally speaking, women are the ones that are responsible for like young kids when kids are born, right? And so you want a person who's taking care of a young kid who's completely dependent on others. You want them to be more perceptive of threats in the environment. And so on average, women are a little bit more, responsive to threats, even threats that are imagined and don't exist. Right? So that's why these conditions tend to be a little bit more common in women. Generalized anxiety disorder. This one's like the more severe type of this, right? You get this for at least 6 months, and it interferes with everything, right? It interferes with your job, interferes with relationships, interferes with everything. And you have concerns of those types of relationships, concerns about your job, right? Everything becomes a concern for you. Your health, your finances, your relationship status, your job, like things that are minor, even just like regular chores will give you like crippling anxiety. Can't stop worrying is a common complaint in these patients. They're feeling on edge. They get fatigued as well. Bruxism, grinding of the teeth, especially at nighttime. We're going to talk about PTSD. This is something that happens with PTSD patients. It gets to the point where it's so bad that the patients sometimes have to get dental work to repair their teeth because their teeth are so damaged. Some of you guys are going to go into dentistry. You might see PTSD patients that have destroyed their teeth through grinding their teeth at night while they're sleeping. This happens to people. horrible stuff. This is from the DSM-5. This is your generalized anxiety disorder criteria. Restless, feeling keyed up or on edge, easily fatigued, difficulty concentrating, irritable, muscle tension, sleep disturbances. So those are some of the common symptoms. And here's a questionnaire. This is like literally what you use when you're diagnosing your patient. You go through this questionnaire, patient health questionnaire, GAD-7. Feeling nervous, anxious, or on edge. If you're feeling it every day, you would mark 3. Not being able to sleep, worrying too much about different things, trouble relaxing, being restless, that it's hard to sit still, being really annoyed. Right? I definitely fit that one, especially when I'm driving. Feeling afraid as if something awful is going to happen. Right? Those are all things that you would see with generalized anxiety disorder. So that is like one of the more severe of them all. Yes?
The one question I have, like, I have so many friends with anxiety.
Yeah.
And they have, like, benzos as a prescription.
Yeah.
And, like, we've had lots of discussions of should you take that when you're having a panic attack or should you try not to take it? And that's my question is, like, because the panic attack is a symptom, like, I always was under the assumption of, like, oh, try to take the little stuff possible and try and fight it.
Yeah.
But then also people have told me, like, well, you really just need to stop it in that moment and then you'll be fine, and you don't want to, like, have someone then freaking out obviously even more about, like, should I be taking this thing? So what I'm trying to ask is it detrimental to have somebody take something in those moments because over time they just won't be able to control it? Or is it more like this thing is not usually supposed to happen anyway, so we can take something, like, for that scenario?
It's such a complicated issue, right? Because first and foremost, benzodiazepines are addictive.
Yeah.
Right? People become addicted to it. And can you die from a benzo withdrawal? Yeah. It's like alcohol withdrawals. Basically the same type of thing, right? You're like overstimulating the GABAergic receptors. Those receptors get downregulated. When you don't have the GABA drug, now you don't have enough stimulation of those GABA receptors, and now you go into autonomic instability. You have basically like heightened excitability. So that's why they're dangerous drugs, because they're addictive and they can have fatal withdrawal symptoms. Now, the counterpart to that is, do you want to be living with crippling anxiety, right? So that's why you couple this with not just pharmacotherapy, but you also couple it with cognitive behavioral therapy. You go see a therapist. And with CBT, you can learn techniques of having how to cope with anxiety when you can start seeing the symptoms of them coming on, right? Maybe you can do breathing exercises, like boxed breathing, right? You familiar with that? So you could do boxed breathing that can help to reduce your symptoms, try to relax, and just be cognizant of the anxiety attack. Like, because you can control these things, sort of. Because these things are physiological, fundamentally. And it's part of the autonomic nervous system. So can you really, truly, like, control it? You can try to, right, with certain techniques, breathing techniques, relaxation techniques, and things like that. But benzos, it's a sticky situation because some people really need it, right? And there's different dosages, too. You can take low-dose benzos. And there's short-acting versus long-acting benzos. The short-acting ones are the ones that have a higher addictive potential, because you get the high quicker, right? It doesn't last as long. Whereas the long-acting have a lower abuse potential, right? It takes longer for them to have the effect, but they also last longer. So there's different pharmacological approaches you could take with anxiety. But what I advise someone to avoid meds whenever they can, yeah, if they can, absolutely, That's what I'm doing. Or just avoiding meds. Yeah. Yeah, my best friend gets this. He's been prescribed benzos. He filled his prescription. He's like, should I take these? I'm like, it's up to you, man. He's like, I'm going to try not to take it. For him, having the benzo pill gives him solace.
That makes a lot of sense.
He feels like, if I have a panic attack, at least I have that there. I know I can take it, right? So it's like a comfort, yeah. It's like you have an escape if you need it. You fainted with anxiety?
Memory loss, yeah.
No kidding. Wow.
I have GAD, but I haven't tried any meds because I'm just trying to not get addicted to anything.
Yeah.
So just like doing things I like, not really doing school all the time, so it's always like hard on myself.
Yeah.
Giving myself that leniency. It's okay not to be perfect.
Yeah.
Kind of.
That's good.
Down a little bit.
That's good. I always look at my 4.0 students. I'm like, man, what are you doing, dude? Like, it's cool to have a 4.0 and all, but at the expense of what? Like, how's your social life? How's your family life? How's everything else in your life?
My
like,
anxiety definitely brought my GPA down, but I'd rather have that than
yeah, yeah. I mean, it's okay not to be perfect, right? I look at I commend students who can do that, who can like have like incredible, impeccable grades, but also manage their social life too. Like, that's awesome. Good on them. But if you have this generalized anxiety disorder and you're trying to be a perfectionist, like, maybe it doesn't go so well. Yeah, maybe calm down a little bit. You know, take it easy. There's more to life than getting a 4.0. You know.
I'm just trying to graduate.
Yeah.
Not fun though.
All right, let's do a.
While you do the quizzes too, I'll ask you another question.
Okay.
So then my other question is, speaking for a friend, of course, if you're smoking weed in a situation like that, as opposed to taking a benzodiazepine, then I'm thinking like, that is my other question is like, you're still treating it with something, but it doesn't have the potential of killing you or being quite as addictive.
When it comes to THC and any of the cannabinoid compounds, they have medical properties to them. I mean, they have therapeutic properties. If used correctly, can they be abused as well? Can THC be addictive? Absolutely. Anybody who says that it's not addictive doesn't understand addiction. Like, you can be dependent and addicted to marijuana. But can it be also medically useful to treat certain things like anxiety, like insomnia, right? There's a lot of things that can be used, that THC can be used for. And so if it works, it works. In my opinion, so long as it works and it does what you're hoping it does, and that you're not just using it as a crutch or maybe just like abusing it, then in my opinion, I'm cool with it. Yeah. Yeah. It helps people with insomnia. Absolutely. Am I advocating for drug use? Not technically, but different strokes for different folks, right? There's some people who take a very hard line on compound. Like, I worked with a lot of doctors and psychiatrists that, like, if you took like one sip of alcohol, they would be like, oh my God, you're like an alcoholic. It's like, dude, calm down. So there's some people who are really hardcore about that kind of stuff. But I take a very libertarian approach when it comes to drugs in general. I think the drug laws that we have on the books are just so egregiously like unjust that they need to be completely like revamped, in my opinion. But that's my opinion. Everyone has their own opinion, and you're entitled to it, even if it's wrong. All right, let's do a couple questions. I think someone signed in twice, which, whatever. You did? All right, everyone point and laugh. Just kidding. It's all good. So are you answering the question twice? You're like, all right, I'm going to select A on one account. I'm going to select D on the other account. Huh? I know, I've had so many. The ticking. Yeah, I've had so many students be like, dude, that's like, the sound on that is just too much, man. I can't. All right, so you guys got this right. Yeah, so this is bipolar 1. 30-year-old male presents to the psychiatric clinic. History of recurrent episodes of mania and depression. Okay, where's that here? The patient reports he's been planning on starting a new enterprise that will revolutionize the neuroscience industry. Over the past 8 days, the patient spent the majority of his life savings in the process of developing this revolutionary technology. Obviously didn't really work out. What is this patient's diagnosis? Bipolar 1. I will say, though, a lot of people with bipolar, they might seem crazy and then they develop like something amazing, right? A lot of our entrepreneurs, lots of entrepreneurs have this personality, right? Have these types of traits. And sometimes they succeed wildly. Sometimes though, they fail wildly. When you're an entrepreneur, you're basically gambling, right? Because the idea that you're creating might be amazing or it might not stick. And if anyone of you guys know an entrepreneur, or maybe even yourself started a business, you know that it's really tough. It takes a lot of work. You put a lot of time and energy into something, and you just hope that it works. And sometimes it doesn't, which is okay. Failure is all right in life. You know, you just get back up and start over again. What's up?
Okay, so another question with this stuff. Like, obviously you have like a diagnosis level, and then you have like normal people over here, and then you have all the in between.
Yeah, it's like a bell curve.
So is it,
right?
That works for this kind of thing as well? Because I'm also thinking like, oh, like literally just personally, I would do some of these things, but not maybe to the extent that it would be a diagnosed thing. So then I'm like, okay, is there like that whole wide range of people?
There's totally, I think everyone is on a spectrum on some, to a certain degree, right? Like everyone experiences anxiety. I experience it. All of you guys experience it. Some people experience it more so than others, right? Same thing with depression. Like we all get sad and bummed out, right? But it's subclinical. You don't necessarily need to go on a drug for it or go into CBT for it. So yeah, it's on a spectrum. Like, you know, I know some people that are like, I think you're schizophrenic. I'm not going to say anybody in my personal life, but like there's someone that I know in particular who I'm just like, I'm pretty sure she's schizophrenic. And she should probably be on meds, but she's able to function. You know, some people have like crazy ideas, and you know, everyone's on a spectrum. Yeah, that's my long story short is that it's a bell curve, and we're all going to fit somewhere in that bell curve. But some of us will be on the extreme ends. And that point, when it becomes destructive and it starts interfering with your life, then you probably should get some sort of like intervention. One of my favorite things in schizophrenia is these different speech patterns. There's tangential speech versus circumstantial speech. With circumstantial speech, they'll like go off on these tangents, but then they'll eventually loop their way back around to like the main thing that they were trying to talk about. Versus tangential speech, like this person, they just go on tangents and it just never goes back to like the original thing that they were trying to talk about. So tangential speech is wild when you see it in the clinical setting. So this person, obviously, schizophrenia, right? They got social withdrawal, disorganized thoughts, auditory hallucinations, and they have these bizarre speech patterns like tangential speech. If you started a pharmacological approach to a patient like this, you're going to want to give them an antipsychotic. And the mechanism that a lot of antipsychotics have is that they reduce dopamine. If you have too much dopamine, you're going to have psychosis. That's why there's cocaine-induced psychosis, amphetamine-induced psychosis, right? You can get psychosis from different stimulants, and it has to do with too much dopamine in the brain. So not GABA, not serotonin. It's going to be dopamine. Okay, so make sure you know that schizophrenia is associated with an excess of dopaminergic activity in your brain. Good. Most of you guys get this right. So yeah, this patient has major depressive disorder. Serotonin could be implicated. Also other neurotransmitters like norepinephrine, right? You have SNRIs, for example, that help to prevent the reuptake of norepinephrine as well. Dopamine could also be involved in depression as well. So good job, guys. Let's do one more of these, and then we're going to switch gears into plasticity. Yeah, you guys do the rest of the quizzes on your own time. So this is a patient that's presenting with chronic worry, muscle tension, restlessness, it's interfering with their day-to-day activities, concerns about so many aspects of their life, work, health, but there's really not that many issues in reality. Like it's just their misconception or their perceptions, their own perceptions that aren't true. What's the pharmacological approach that you could use, right? So GABA agonists. You don't want to give a GABA antagonist. For this patient, you want to give them a GABA agonist, if anything at all, right? You'll give them a benzodiazepine. It's a GABA agonist.
And then NRIs increase norepinephrine because like it's not getting absorbed as much, so that can increase it. And, like,
yeah, if you gave them a norepinephrine reuptake inhibitor, that would really exacerbate their anxiety. That would make them, yeah, that would give them like excessive sympathetic activation. Yeah. All right, guys, good. Let's move on. Good job on that. Any questions on any of the stuff that we covered in this section? Cool. I mean, I'm like super biased when it comes to psychiatry. Like that's like one of my favorite fields. So yeah. Now we're going to move into something that's not exactly terribly exciting. The first part of neuroplasticity is like, it's okay. It's important. It's important. It's important stuff. But it's not as fun as psych, unfortunately.